Good afternoon, everyone. So my name is Gabriel Biergan, and it's a great pleasure to welcome you on this second webinar organized in collaboration with EU JAMRAI 2 and EUCIC, the European Committee for Infection Control. As you probably know, we are trying to run this webinar quarterly. So this is the second one on ventilator-associated pneumonia and on the diagnosis and prevention of these infections. So just a couple of information before starting this session. So first, as you probably know, ECMID created a group to develop guidelines on VAP prevention. So it's an ongoing work, and we are trying to deal with it and with the objective to release the guidelines in the coming 2 years. So this is the first point. The second one is about EU JAMRAI activities. So there is, as you probably have seen, a form circulating on the need assessment for peer-to-peer activities in infection control. So if you don't have this link, please come to us, and we can forward this link to participate. And the last one is the next webinar. So next webinar will be the 5th of September. In co-organization with ECDC on the surveillance of infection control of healthcare infection, and matching this surveillance with the IPC implementation, which is sometimes a challenge. So it's now time to start this session. It's a session in collaboration with the Statens Surveillance Institutes, but also the European Study Group on critical ill patients. And I will hand over to Despina and Jet for sharing this session. So thank you very much.
Thank you, Gabriel. I'm Despina Kouledi. I'm intensivist with focus on infectious diseases, and currently I work in the critical care department of King's College Hospital in London.
Hello, my name is Jette Holt, and I'm an infection prevention control nurse. I work at State SIM Institute in Copenhagen, and I work with prevention of infections like, for instance, VAP. And I am also very interested in behavior change.
I would like to introduce you now our first speaker, Professor Jean-François Timsit, for Infectious Intensive Care Unit, Bissac Claude Bernard University Hospital of Paris, and also one of the research directors of the very large research unit of infection at the microbial modeling evolution of Paris. Your floor is yours, Jean-François.
Thank you, Despina. Hello, everybody. I will try to share my screen. I hope everything is good now. Do you see my screen?
Yes.
It's okay, good. So the question that has been asked by the organizer are not so easy. How should we define the VAP for reliable diagnosis and monitoring? Well, I think it is a $1 million question, and I will try to answer as far as I can on this question. Of course, we need both to have an individual diagnosis for caring the patients, and perhaps to estimate the patient's outcomes individually, but also as a global quality of care indicator. Would like to identify the population that are really at risk of VAP, and are able to have a case mix, at least adjusted strategy to improve the quality of care, and perhaps to use it for benchmarking. If we look to the literature that lasts for more than 30 years, as you see, there is, of course, some pro-argument to use it as a benchmark tool, because that is not because VAP is a very difficult to diagnose disease that we must ignore it, since it is associated with mortality and with a lot of consumption of antimicrobials. But on the contrary, benchmarking VAP rates as outcome parameters is considered since more than 30 years between institutions as hazardous and potentially misleading. And we will discuss it. You should have in mind what is an appropriate endpoint for a clinician in order to make the diagnosis, but also for ICP, and it is, of course, important and crucial to have definitions, both for treating patients and for successful interpretation and infection control program or any intervention that are done. What are the good determinant of a good endpoint? It should be objective, so with little variability in measurement between observers. It should be frequent in order to be sufficiently powerful to detect variation. It should be easy to measure, and in order not to take too many healthcare workers in order to calculate and to evaluate the process. It should be internally valid, that is to say that it should be related to the real disease being studied and related to a true patients-related or healthcare system-related outcome. And it should be externally valid in order to target not only the internal population of one particular intervention, but also external population outside of the first one. Let's have a look to the data that we have about the various definition of VAP. For example, this study in Brussels, more than 1,800 patients ventilated for more than 48 hours. They collected a lot of diagnostic points associated with ventilator-associated pneumonia. You have it in the table 2 with a lot of things that are collected for each patient. And they also collect a traditional definition from the CDC, HELIX, and so on. And they try to define the possibility of combination of VAP diagnosis, and there was 89 possibility for combinate the component of the definitions in this 1,800 patients population. And what they found is that the incidence of ventilator-associated pneumonia was very, very different according to definitions. For example, if you use CPIS, it was 42% incidence. If you use Johansen criteria, which were very strict using anatomopathology, empyema, etc., it was only 4%. But there was a very important variation, so various results. But what it was really interesting and important to have in mind is that the correlation between all the definition was not so good. If you consider that a good correlation is near than 1, you see the hair here that are very, very poor. So poor correlation, poor internal validity between the definitions that are used from one group to another, for one multinational organism to another, and I think it is very important to have in mind. They then use the criteria, the 89 definitions they proposed, and they found that if they use a more stringent criteria, they will have a very important mortality that goes from 50 to 80% of the people that with a diagnosed VAP, but they will have also a later diagnosis of VAP that goes in median to 4 days to 8 days, however, according to the definition used, and also an increase of the duration of stay that will be very, very different, or very important for a very stringent criteria, and not very important if the criteria will. So very important to have it in mind if you need to try to design a program and to see a benefit for your infection control program. As you know, Michael Klompas tried to develop an automatic process in order to detect automatically something that is quite near to ventilator-associated pneumonia, called infection-related ventilator-associated complication. You know the definition, ventilator-associated complication was an automatic way to look at the worsening of oxygenation in patients under mechanical ventilation. If you had temperature, abnormal white blood cells, and the modification of the antibiotic that continued for 4 days, they defined high VAC. And after, they consider possible VAC as an high VAC plus a culture that were positive, or a purulent secretion in the sputum or empyema, or a positive Legionella antigen. And of course, you should have in mind the ventilator-associated pneumonia traditional definition, new infiltrate, systemic criteria, pulmonary criteria, and the new ventilator-associated tracheobronchitis, which is a VAP without radiological signs of pneumonia. And if you look to the figure on the right, you see that all this component, all these definitions are related to some particular people that are, some of them are taking part of all the definitions, but other patients could have a VAP without having an IVAC and vice versa. And it is important because there is no internal validity of the IVAC, and it has been demonstrated by many studies in order to be a synonymous or something that is usable for defined VAP. The external validity should also take into account the case mix, because if you look to only intubated patients and not tracheostomized patients, it will be very different. The pre-existing pulmonary disease will also be very important, for example, for purulent secretion. For new radiological infiltrate, IRDS patients are very different. Not considering ECMO patients will be very difficult, and the worsening of oxygenation in the ECMO is impossible to define. An immunocompromised host, as you know, neutropenic patients have no new radiological infiltrate, and also very difficult to interpret. The other issues for infection control practitioners, and in order to count a process, is should we use only the first episode or all the episodes? If you use all the episodes, how could you define relapse, recurrent, superinfection in order to be reliable? What is the denominator? Do you look at the number of patients, the duration of mechanical ventilation overall, or the duration of mechanical ventilation before the first episode? All these points have been addressed by many papers, and the answers are very different according to papers, so really an issue. What about the clinical diagnosis? Of course, as a clinician, I need to diagnose something that is related to a new sepsis, a new worsening of respiratory status, probably with new and persistent infiltrates as a pneumonia, as a classical pneumonia, and something with most of time purulence of modification of aspirates. The question is, and it is a very important question, is for which patients may diagnostic microbiological test not being performed in order to define properly and not to sample everybody, because if you do it, it will be quite impossible to define ventilator-associated pneumonia properly. As we all know, the accuracy of the traditional point are not so good. No more than 50 to 60% for fever, white blood cell, purulence, etc., etc. And none of the traditional diagnostic point are really accurate to diagnose ventilator-associated pneumonia. We recently asked to a lot of international experts what are the points that are very important in order to have a clinical suspicion of ventilator-associated pneumonia. A 0 score is nothing at all, and a 5 score was related to a high score, a high suspicion of having a pneumonia. And you see that it is worsening of gas exchange and hypotension requiring vasopressor that were associated with the most important value for clinical suspicion of ventilator-associated pneumonia. And the traditional signs of clinical VAP, fever, hypothermia, purulence, regression, etc., of clinical VAP are no longer the most accurate ones for the experts in order to have a clinical diagnosis of suspicion of ventilator-associated pneumonia. And I think it is important to have it in mind. Should we use biomarker? I will not go into detail, but all the consensus said that it is not possible to use CRP, procalcitonin level, in order to define the population that have a clinical suspicion of pneumonia or a clinical pneumonia, and that will require some microbiological sample. So we need to abandon this kind of thing. What about chest X-ray? I mentioned that it is not so good, but the specificity is especially poor because new radiologic infiltrate in ICU is quite common and not always related to an infectious process, and the specificity is considered about 30%, perhaps 50% at the maximum. And the sensitivity is no more than 60%. And there is a subjective interpretation and inter-observer variability that has been demonstrated for a long time. Probably CT scan is good and thoracic ultrasound is also good, but not applied to all the patients. So very difficult to use it for an IPC program. And it is a question of ventilator-associated trachobronchitis, the absence of radiological infiltrate. Should we consider that it is a ventilator-associated pneumonia or not? Well, we are not sure at this time. In my opinion, part of the VAT are in fact early ventilator-associated pneumonia with minimal infiltrate. And probably a substantial part of VAT are only bronchitis that are not requiring no more than physiotherapy and no antibiotics. So very difficult, but very important, because if there is a continuum between VAT and VAP, you should consider, and it is probably true because it increases the duration of mechanical ventilation. It is very important for the counting process because if you use VAT in the definition, you will multiply by 2 the number of ventilator-associated pneumonia. And we all know that VAT has been also created by the US people in order to decrease the prosecution risk. So very difficult to define it and very difficult to know if it is needed to treat this kind of patients, if it is really an infectious process related to pneumonia. So, and then resolve issue at this time. Should we perform bacteriological exams? It has been addressed by all the consensus, and the answer is yes. So we need definitely to perform microbiological exams to confirm the diagnostic of ventilator-associated pneumonia. But the main question and the remaining question is which one? And it is very difficult because if you look, for example, to the ELIX definitions, you have the clinical suspicion of pneumonia, more than 53 ventilator-associated pneumonia based on a clinical suspicion of pneumonia. And if you take, for example, qualitative tracheal aspirate as a microbiological diagnosis, you will have 46 pneumonia. That is to say that about 90% of the clinical pneumonia will have a definitely confirmed ventilator-associated pneumonia. On the contrary, if you look to quantitative bronchoalveolar lavage definition, the rate of pneumonia will be only 11, that is to say 20% of the clinically suspected ventilator-associated pneumonia. So a considerable difference according to the antibiotic, to the microbiological lab exams that you will take. So what are the main points to address here? First of all, do not sample patients who are not suspecting of having VAP. I think it's really important. sample all the patients suspected having VAP, and take samples before any change of antimicrobial in order to interpret the results. Because it will not be possible to stop antibiotic early and considering that it is a false positive, it will not be possible to diagnose a pneumonia if you start antibiotic before. And one of the questions for my colleague and the second speaker will be, what could be the impact of a prophylactic inhaled or IV antibiotic therapy as a prevention strategy in the diagnosis, in the microbiological diagnosis of VAP? I have no answer about it, but I suspect that it will be important. My opinion, and it is the opinion of the European consensus, is to sample quantitatively in order to improve reliability and the ability to stop antimicrobial in order to not to consider that it is a ventilator-associated pneumonia. Another remaining question is the place of the molecular methods. And we know that it is biologically accurate. We know that the viruses are probably associated with some ventilator-associated pneumonia. The role of quantification has not been really addressed, but that we know, what we know at this time is that in some countries, especially in UK, MPCR is now in the definition. So there is in the definition the use of MPCR for diagnosing microbiologically ventilator-associated pneumonia that is included. So I think it is an important point to address and very difficult to have a final answer on it. My only point at this time as an hospital decision is to pick up a definition for an institution and apply it consistently. I think it is very important if you want to look at your program. In order to answer, to give a final answer of the question that has been asked to me, what could be the solution to have an appropriate endpoint, to be objective? A little variability will need not to use routine surveillance culture in order not to have some noise in the interpretation. The more you sample, the more you increase the antimicrobial consumption and the more you increase the number of ventilator-associated pneumonia. So only to sample patients really defined with a suspicion of ventilator-associated pneumonia, and we saw that it is quite difficult. You should have this kind of discussion with the clinician in order to define it properly. Probably the clinical suspicion is a good way to do it. Sample patients before antibiotic start will be very, very important to have in mind, and add clinically documented VAP, because in some cases we will start antibiotic before sample. The question of ventilator-associated tracheobronchitis is a very difficult issue. I consider that when we start antibiotic, it is a VAP. And when we are not starting antibiotic, it is a bronchitis, and that's it. It should be frequent, and of course, for the frequency, if you take a very stringent definition, the frequency will decrease, but the impact will increase. So difficult decision to take. It will be easy to measure, and probably IVAC is good, but not accurately reflecting VAP. The internal validity is also really a problem. And in order to have a good internal validity, I think that not only VAP, but also vital status, length of stay, length of mechanical ventilation, and duration therapy as a multi-component outcome should be used in order to define the impact of some particular infection control program. And the external validity is very, very difficult. There is a lot of case mix issue. I think you should integrate in a dashboard the rate of ECMO patients and the individual ECMO patients rate, IRDS patients, to be a surgical or a medical patients, the rate of immunocompromised patients, and probably the severity scores should be included in a dashboard in order to obtain something that is compatible with the quality indicator. Thank you for your attention.
Thank you very much, Jean-François. For the attendees, you're invited to submit your questions in the Q&A box. They will be answered by the end of the webinar session. And I will move on to present our second speaker, Nikolaos Vasilis, the of the Department of Infectious Diseases of the German Medical Institute of Cyprus. Your floor is to Nicholas.
Thank you, Dr. Poulenti. I hope my screen is okay. I have no conflict of interest regarding this presentation. The outline of the presentation includes a short mention of the burden and the risk factor for ventilator-associated pneumonia. We are going to analyze pathogenesis of ventilator-associated pneumonia. We are going to describe the three basic components of the pathway for preventing VAP. And at the end, we are going to discuss the specific VAP prevention strategies. What is the motivation to prevent VAP? We know that within ICU, VAP is the most frequent nosocomial infection, impacting 20 to 36% of critical ill patients. The incidence rates vary, and factors such as diagnostic criteria, as the previous speaker has described, preventative measures, and patient and geographical variations influence these incidence rates. The reported mortality rates for VAP span a wide range between 24 to 76%. However, attributing mortality solely to VAP is complex due to the severity of underlying illnesses and diagnostic heterogeneity with ICU population. But in my opinion, and in the era that we are living now, one of the most important motives to prevent VAP is the fact that VAP increases hospital length stay by an average of 4 to 9 days, and also increases healthcare costs by approximately £9,000 per patient. And believe me, governments and hospital managers are very interested in the cost of hospitalization. Regarding now the risk factors that are correlated with ventilator-associated pneumonia, in this all-time classic paper written by Professors Alp and Vos approximately 20 years ago, these factors are divided in three main categories: host-related factors, intervention-related factors, some other factors. Some of them are non-modifiable, such as the age, the presence of chronic lung disease, the presence of neuromuscular disease, while some others are modifiable, such as the PIPA, the presence or not of nasogastric tube, and others. In order now to devise preventive strategies for VAP, it's crucial to understand the pathogenesis of this healthcare-associated infection. And currently, we have a transition from a classical view of VAP as the invasion of sterile environment by pathogens to a more complex view that includes the role of the pulmonary microbiota and its dysbiosis. Thus, at the left side, you can see the classical model where infection is shown by the presence of pathogenic bacteria with black color inside the lung, leading to inflammation and VAP. While in the new model, at the right side, infection is leading to the concept of dysbiosis in the lung, represented as lack of diversity and proliferation of pathogenic bacteria with black color too inside the lung. In this new model, dysbiosis occurrence is linked to the gut-regulated immunomodulation and specific ICU factors such as mechanical ventilation duration, length of stay, the utilization of steroids, adequate antibiotic prophylaxis, and others are related to this new model proposed pathogenesis. Unfortunately, the medical literature has focused only to the classical model and the mechanism related to the classical model of pathogenesis of VAP. And we consider that microaspiration of secretions containing bacteria either from oral cavity or from the stomach is one of the main pathogenetic pathways for ventilator-associated pneumonia. Also, the formation of biofilm within the lumen of the enterotracheal tube or tracheostomy tube is also another pathogenetic mechanism of the classical model. We can have also contamination of the artificial airway directly without previous colonization due to the use of an incorrect aseptic technique during the incubation procedure, or aspiration of secretion, or aerosolization by contamination of ventilation device such as gas blenders, flow regulators, etc. While very rarely hematogenous route is a pathogenetic pathway for ventilator-associated pneumonia through the dissemination of bacteria to the lower respiratory tract, the lungs, from distant sites of local infections. I will stay a little bit in this slide because the endotracheal tube has a crucial role in the alterations of the airway anatomy and physiology that may lead to the development of VAP. So in the figure A, we can see that during the first day of mechanical ventilation, pathogens responsible for VAP that are found in the lower respiratory tract are mirrored by the aura microflora. And usually these bacteria are organized as biofilms on the teeth. And this allows them to survive to extreme conditions. Over time, in the B figure, pathogens can be found in the inner lumen of the ETT as a biofilm. Okay, and as soon as the ETT cuff is inflated, you can see that in the C figure, secretions accumulate in the subglottic space due to gravity. And this is a very important stage because these contaminated secretions can continuously leak into the lung through the inflated cuff because of microscopic folds on the outer surface of the cuff. These folds are called microchannels, and manipulation of the ETT, the oral care, repositioning of the ETT or the patient, and patient transport are associated with increased aspiration through these microfolds into the lungs. And finally, in the A figure, the functional tracheal mucociliary apparatus is also impaired by a suboptimal humidification and heating of the inhaled air, as well as because of the presence of the inflated cuff. And by gravity, these injuries facilitate the entry of pathogen-laden secretions into the lungs. Now, specifically now for the prevention of ventilator-associated pneumonia, in the past 3 years, two published papers with specific recommendations exist in the literature. The first comes from the Society of Healthcare Epidemiology of America, ESGCIP, and provides practical recommendations to assist acute health hospitals to prioritize and implement strategies to prevent VAP, not only in adults, but also in children and neonates. While last year, another publication by the International Society of Infectious Disease provides recommendations on preventing VAP in adults, while addressing factors in high income and, very important, that in low to middle income countries too. Now, the three main components of the pathway to prevent VAP include some necessary requisites, include a multidimensional approach for the implementation of the VAP prevention strategies, and includes also these specific VAP prevention strategies. Regarding the necessary prerequisites, these include the availability of assets for delivering suitable education and training, and this may include regular workshops, hands-on simulations, competency assessments to maintain adherence to guidelines. But it's very important to remember that this content should be tailored to the facility patient population and local and microbial resistant patterns. In the Mediterranean Basin, we have a huge problem with AMR patterns in the hospitals. The second prerequisite element is a sufficiently staffed infection prevention program, which will be responsible for identifying patients who meet the surveillance definition for VAP, no matter what is its definition. Okay, and this infection prevention program is also responsible for conducting audits, reviewing clinical data, and ensuring accurate VAP reporting. We need the information technology support, especially in the era of artificial intelligence. IT departments may help us to streamline data collection and ensure precise tracking of cases and mechanical ventilations days. And while at the same time, these systems enable efficient and accurate computation, facilitating real-time monitoring and of VAP rates and allowing for timely intervention and adjustments in infection control strategies. This is very, very important. The real-time monitoring and communicating data regarding VAP rates and the timely interventions in infections control strategies. As it is the case for any healthcare-associated infections, we need an effective laboratory support for reasons that we can all understand. And also, finally, last but not least, providing epidemiological bulletin to doctors is essential for effective empirical therapy. And this data enables doctors to make informed decisions, tailor treatments, and improve patient outcomes at the end of the day. Regarding now the multidimensional approach that is being recommended in order to implement specific ventilator-associated pneumonia prevention strategies. This approach includes bundles, of course, as it happens with all healthcare-associated infections. And when we are talking about bundles, we are talking about single sets of evidence-based practices that, when implemented, collectively improve the reliability of their delivery and enhance patient outcomes. Education, again, education is very important in this stage again. And healthcare workers that manage patients that are under mechanical ventilator should receive training and demonstrate competence according to their role. Surveillance, of course. Internal reporting of VAP rates in order to bolster internal hospital quality improvement initiative, emphasizing the importance of communicating them to senior leadership, to clinicians, and also to the management. Okay. Compliance, we should monitor in compliance with recommendations to prevent VAP by using checklists or by assigning knowledgeable healthcare providers to oversee this task. And finally, the performance feedback, which may include charts displaying data on attending healthcare providers' monthly compliance with infection prevention practices. I will stay a little bit to bundles. I will present two studies. The first study is a systematic review meta-analysis that included 36 studies in order to assess the effectiveness of ventilator care bundles in preventing VAP. And this study showed that implementing care bundles significantly reduced the number of VAP episodes. And the most utilized components in these bundles were head of bed elevation and oral care. And in another study, recent study, a systematic review to examine the impact of these bundles on preventing VAP, 18 studies were included. Key bad components were daily evaluation of sedation interruption, assessment for extubation readiness, head of bed elevation at 30 degrees, cuff pressure monitoring, prophylaxis for coagulation disorders, and oral hygiene. Noteworthy, head of bed elevation at 30 degrees was universally reported in all studies. And again, this study, secondary study, of course, showed that implementing bad items was associated with a reduction in VAP incidence. And the third component of the pathway for preventing VAP, apart from the prerequisites and the multidimensional approach, is the VAP preventive strategies per se. Before we get in this, we must highlight and underline the importance of hand hygiene, as is the case in every healthcare-associated infection. Okay. Now, for VAP prevention strategies, according to the consensus paper that was published in 2022, these can be divided in four major categories. The essential practices, which improve objective outcomes or are outcome neutral but cost saving, very than this. The second category is the additional approaches which improve objective outcomes but carry some risk of harm for specific populations, and also include interventions that lower VAP rates but insufficient data exists to determine their impact on objective outcomes in patients. The third category includes the not recommended intervention, which they do not improve VAP rates and they don't have no impact, or they may have even negative impact on objective outcomes related to patients or to financial parameters. And finally, the last category, the fourth category, interventions with no recommendation, where no impact on VAP rates or other patients' outcomes these recommendations have, or they have an unclear impact on cost. Regarding the essential practices, these include the avoidance of intubation and prevention for intubation by using either high-flow nasal oxygen or non-invasive positive pressure ventilation, whenever, of course, this is safe and feasible. The minimization of the sedation. It's crucial to avoid benzodiazepine, prefer propofol or dexmet, but benzodiazepines are not recommended. Also, it's very important to use a protocol to minimize sedation and also to use a protocol, a ventilator ventilation protocol. Another essential practice is to maintain and to improve physical conditioning by physiotherapists and by other methods. Of course, to elevate the head of the bed to 30 to 45 degrees. This is a cost-efficient and non-time-consuming intervention. Very important to provide oral care with toothbrushing, but without chlorhexidine. To provide early enteral versus parenteral nutrition. To change the ventilator circuit only if visible soil or malfunction. This practice has no impact on patient outcomes, neither positive nor negative. Nevertheless, is cost effective. Okay, it reduces the cost of hospitalization, and this is the reason that it's considered an essential practice. And another essential practice proposed by the International Society of Infectious Diseases in 2024, not included in the paper published in 2022 by ESGCIP and Infectious Disease Society of America, is the use of continuous cuff pressure control. In the next 2 or 3 slides, I will discuss the provision of oral care with toothbrushing but without chlorhexidine and the utilization of continuous cuff pressure control. Now, regarding oral care with toothbrushing, in this Cochrane Library review published in 2020, it was shown that chlorhexidine, as part of oral hygiene care, probably reduces the incidence of VAP in critical ill patients. Nevertheless, no difference in mortality, duration of mechanical ventilation, length of stay in ICU was found, although the evidence of certainty was quite low. And the oral hygiene care, including both antiseptics and toothbrushing, was found to be more effective than oral hygiene care with antiseptics only. And in another very interesting study published in 2022, I think, in the chloral study, a multi-center stepwise cluster randomized controlled trial, it was found that no difference existed between patients with and without oral chlorhexidine administration in terms of mortality ICU or in secondary outcomes such as infection-related ventilator-associated complication or procedural pain. However, oral chlorhexidine the adoption was associated with improved oral health. We must just keep in mind that all included patients in this study had high or extremely high risk of death, and this is very important for the next slide. Regarding again the utilization of chlorhexidine as a part of the standard oral hygiene care, this study which examined the selective digestive or oropharyngeal decontamination plus the administration of topical oropharyngeal chlorhexidine for prevention of death in a general intensive care showed that selective digestive and oropharyngeal decontamination had a correlation with a reduction in mortality due to VAP. Nevertheless, on the contrary, fluorexidine utilization was linked to an increased risk of mortality. And another study published in 2018 was a single-center cohort study which investigated the impact of fluorexidine oral care on mortality in general hospitalized population. That means patients intubated and non-intubated, and ICU patients and non-ICU patients. Exposure to fluorexidine was associated with an increased risk of death in all patients except those with extreme initial risk of death. And the increased risk of death was mostly observed in patients who did not receive mechanical ventilation and were not admitted to ICU. And why is this happening? Now, there are several possible explanations. I think that the most plausible pathogenic mechanism explaining the relationship between antiseptic mouth washes and mortality is the disturbance in nitric oxide production and homeostasis. Nitric oxide is a key messenger molecule in the multiple physiological processes such as the maintenance of vascular tone and vascular permeability, the leukocyte adhesion, the neurotransmission, the mitochondrial respiration, and oral antiseptic seems to affect this homeostasis of nitric oxide by eradication of specific bacteria of our microbiome. Regarding now continuous cuff pressure control, a published study in 2022, it was a systematic review meta-analysis of RCTs. 11 RCTs with approximately 2,000 intubated adult patients were included, and it was shown that continuous cuff pressure control reduced the risk of VAP compared with standard methods, while secondary outcomes revealed no significant difference in mortality, but a decrease in the duration of mechanical ventilation in ICU stay. Nevertheless, the evidence was very low. And in another study published last year, also a meta-analysis study, secondary study, 14 randomized controlled trials were included with approximately 2,000 people. Continuous cuff pressure control significantly reduced VAP incidence compared to intermittent cuff control pressure, and also continuous cuff pressure control decreased the duration of mechanical ventilation, while no significant difference were found related to length of stay or mortality. Now, apart from the essential practices, we have some additional approaches when the essential practices fail to reduce the VAP incidence and the VAP rate in levels that are acceptable by us. And these additional approaches include the selective oral or digestive decontamination only in countries with low prevalence of antibiotic-resistant organisms, because we have studies with benefit only in these settings. The utilization of ETTs with subglottic separation drain transport, especially for patients that are going to be intubated for more than 2 or 3 days. The early tracheostomy conduction within the first 5 to 7 days, and also in these additional approaches include the consideration of post-pyloric rather than gastric feeding for patients with gastric intolerance or at high risk for aspiration. The last two categories in the VAP prevention strategies are the strategies and the approaches that are generally not recommended, such as the oral care with fluorexidine for the reasons I explained in the previous slides, the use of probiotics, the utilization of urethane polyurethane ETTs, the tapered ETT cuff, the automated control of ETT tube cuff pressure, the frequent cuff pressure monitoring, the utilization of single-coated tracheal tubes, the use of kinetic beds, the prone positioning, and the fluorexidine bathing. Also, stress ulcer prophylaxis, monitoring of residual gastric volumes, and early parenteral nutrition are generally not recommended. While the last category includes approaches that they have no recommendation or pending resolution, such as the utilization of closed endotracheal suctional system. I must stress that regarding the approach of frequent coughness monitoring, this was not addressed by the other document published by the International Society of Infectious Disease in 2024, while regarding silver-coated endotracheal tubes, for the ICIG publication, this is considered as a no recommendation approach. It means that it's pending resolution approach, and perhaps in the future there is an indication to use this approach if more studies come up. And by talking for studies related to the silver-coated ETTs, those two studies, the first from Romania, a single-center study in an ICU in Romania, show that the use of noble metal alloy endotracheal tubes reduced the incidence of VAP in the intervention group compared to the control group. Where in another study published in 2022, it was a multi-center study with the participation of 9 ICUs in Belgium, approximately 300 patients, and it was shown in this study that the utilization of silver-coated ETTs was related with a delayed occurrence of VAP in the intervention group compared to the control group. Nevertheless, again, I will stress out that studies in large populations are needed to clarify the benefit or not of the usage of this kind of ETTs. We all know now that we are living in dark times, and in dark times, usually the weak suffer the most. So I find very important to have a slide regarding the prevention of VAP in low and middle income countries. This paper was published in the Journal of Critical Care last year, and it included a multidimensional approach and an 8-component bundle in 374 ICUs across 35 low and middle income countries from Latin America, Asia, Eastern Europe, and the Middle East. And this approach had as target to reduce VAP rate. This bundle, including the optimization of hand hygiene compliance, the assess of readiness to extubate daily patients without contraindication, the maintenance of tough pressure and volume at the minimal classic setting, prevent clinical significant air leaks around the ETT, approximately 20 centimeters of water, I think. The minimization of the duration of mechanical ventilation and the ICU stay, the elevation of the head of the bed to 30 to 45 degrees, the provision of oral care with toothbrushing but without fluorexidine, and the prevention of contact from reaching the patient. And it was shown in this multi-center study that this intervention resulted in a significant VAP rate reduction by 66%, and this reduction was maintained throughout the 39th month period of follow-up. And when I'm talking about healthcare-associated preventions, I always have in mind this phrase by Benjamin Franklin, who famously advised fire-threatened citizens of Pennsylvania in the 18th century that an ounce of prevention is worth a pound in cure. And we must have in mind that a pound is equal to 16 ounces. So prevention is the most effective measure to confront infectious disease, not only into the hospitals, but also in the community. Thank you for your attention with a picture from my homeland, the island of Crete in Greece.
Thank you so much, Dr. Spano-Vassilis. We don't have much time left, so I think what we're starting out with is a question first to Jean-François. If you would give the clinician an advice of what to sample and how to sample to get the best result in a busy world where resources are sparse, what should that be? What microorganism and what sample method?
I'm sorry, I have very important difficulty to hear you, but if I understand well, what could be my advice for a clinical, as the clinical point of view to diagnose ventilator-associated pneumonia. So I think that it is very important not to sample patients if you are not convinced that there is a new episode of ventilator-associated pneumonia, whatever the definition you take. It is also important, and it is a dilemma, not to start antibiotic if you consider that there is a risk that these patients really have a pneumonia. Well, very difficult to address this question. Probably the worsening of oxygenation and increase in, for example, norepinephrine use are good starting points, because we can no longer use temperature, for example, because we use CVVH, continuous hemodialysis and hemofiltration, and we are adapting the temperature, and it is not the patient itself that is responsible for his own temperature. So very difficult to use this kind of point. So probably worsening of oxygenation, worsening and increasing the dose of vasopressor or new shock, and perhaps a new radiologic infiltrate where it is possible to use it. So when you have no underlying high RDS or no underlying pneumonia, are the three main points to have in mind in order to sample the patients correctly. And then to try to start antibiotic at this time. And if the microbiological lab gives you negative results, you stop the antimicrobial and you consider alternate diagnosis.
Okay, thank you so much. So what you say is what you said in your presentation also, that there is no one size fits all. So you have to locally design depending on your demography, etc. So I'll pose the next question to Sven Vasilis. You said exactly the same thing. You presented a lot of articles and a lot of elements in the bundle. Now the clinicians often ask us, if we only have this limited time, then what three things in the bundle should we take as the most important? Some say that it's hand hygiene, oral hygiene, and education. What would you recommend when your clinicians look at you and say, we don't have the time for all that? What is the most important?
Okay, so apart from the provision of education, which is the basis for everything, in my opinion, we are looking for cheap and non-time consuming interventions. So there are some publications regarding hand hygiene, head elevation, and provision of oral care without chlorhexidine. Cheap and non-time consuming.
Exactly. And then there's another question in the Q&A. What can AI provide us with, both in diagnostic issues, but also in preventive? Can it help us pinpointing the patients that we have to be extremely careful about? And can it maybe predict infections before the clinical eyes can see it? So what can AI do? How much should we cooperate with all the tech nerds, not the ones in the States, but all the other ones?
From my side, regarding infection prevention control, I hope that AI will help us in the near future to access to macro data regarding, for example, the education, or regarding charts or checklist for the adherence guidelines, and to reduce the bureaucracy in some aspects of infection prevention control. And because all these activities are time-consuming for someone, for example, to oversee the adherence of the personnel with hand hygiene, with the oral care, etc., etc., etc. And AI in these not so cold aspects of the patient management, I think that can help us a lot. Regarding diagnosis, Professor Tim said, which is a hot issue for me, AI and diagnosis or AI and treatment, I think it's more so is the expert to answer.
Thank you. Ms. Bonnier, did you have a question?
Yes, I have a question to both. It was mentioned in our discussion by Professor Tim Seed. What is the opinion on prophylaxis with short IV antibiotics or NEB, for short term? We have the recent data on that. And so what's your opinion, Professor Tim Seed and Professor
For me, Nicolas,
for both.
Well, for me, well, I really don't know. I suspect that in order to consider the question alternately, I suspect that some of the ICU patients are real immunocompromised patients. And in this case, perhaps there is a room for some particular population for a preemptive strategy. That is to say, we need to treat early with very poor biomarker by antibiotics, this kind of patients. And it is especially the case for comatose patients and patients with neurological injuries, and for ECMO patients where there is probably a sort of risk. The main problem with this assertion is if you start something, when you will stop it. And I don't know. And it is another subsequent question, and that is why I am not starting to do it. But I think there is something. I think we need to move on this direction and try to find some biomarker indicating that the risk is so high that we have to start something.
Thank you very much for the reply, and I will try to sum up several questions for diagnostics in the chat. It is about the correct sampling, and if you agree to evaluate the quality of sampling with the count of white blood cells and epithelial cells in the sample. What sampling you would suggest, okay. And what about the quality of sampling?
We are talking about intubated patients. We are talking about intubated or tracheostomized patients. That is to say that there is no contamination. We take samples that are in the lower respiratory tract. I don't know where, but somewhere. So probably no need to look at the bronchial cells for this kind of patients. The question is proximal or distal. Well, I have been educated for more than 40 years to use distal sampling. So I consider that it is much easier to make a diagnosis using it. But of course, you may use whatever the sample you are comfortable with. I think that quantitative exams are probably better than qualitative one in order to stop the antibiotic early. Because, of course, the bronchus are contaminated when you have an intubation or a tracheostomy.
Other similar relative question is about when to start. So based on your diagnosis and then based on the criteria, how this impact the criteria that you will decide to use for VAP, how this will impact your initial treatment strategy, especially in terms of empirical versus delayed. semi or not targeted therapy? This question comes from Anahita.
Well, the problem is not to start, is the time where you are sampling patients. If you start antibiotic just after having been sampling the patients, the question is when to stop. And do you consider that if the sampling is negative according or sterile or negative according to a threshold, you will or not stop the antibiotic? I am convinced that most of the time it is possible to stop and that it is not a real ventilator-associated pneumonia. But if you are not convinced and you continue the antimicrobial, there is no need for using this kind of sampling, of course.
A question for Nikolaos. How often oral care should be done in mechanically ventilating patients? It's from the chat.
Specific international protocol, 1 to 3 times per day. Most of the ICU follow this frequency, 1 to 3 times per day. In our ICU, it's 1 time per day daily.
Thank you. And there is a question from Phil Hopkins from London about polymicrobial, how we assess polymicrobial VAP, and also the use of a common algorithm all over Europe. For Jean-François?
Well, I have no answer. I think it is a question that it is a 30-year question, old at least. So I think it is very, very difficult to answer. I think that we need to combine antibiotic use and VAP rate. It is impossible for me to have a decrease on ventilator-associated pneumonia rate without a decrease of antibiotic use. So it is impossible. So if you have a strategy that decreases VAP, it should decrease the number of antibiotics that you use. So that's why I am not convinced by many of the preventive strategies that has been published, because there is no impact on antibiotic use. So, and the second endpoint that is important is the duration of mechanical ventilation. And probably if we want to have a common definition, we should use a mix combining VAP rate plus some objective points such as antibiotic use and length of mechanical ventilation.
And I think, like you said, there's a time to stop, and I think the time to stop is now. I think the discussion shows, and the questions also, that this is a complex area. The million-dollar question is still out there, and there's a lot of local discussions and national discussions to be done. And maybe there's place for another webinar on this topic. We would like to thank all the speakers and all the attendants also for bringing focus on this. And Desponia, did you have more to add?
Before we close, there were a question about the recordings. Gabriel, can you explain where they can find the recordings?
So yes, it will be available on the EUCIC YouTube channels, plus on the EUCIC webpage at the same time. So you will be able to get this link there.
Thank you all.
Thank you so much, Gabriel. Thank you all, and have a nice weekend. Bye.